Subscribe now and press the bell icon. Never miss an update.
I would like to introduce our welcoming host, Dr. Piali Mandal. She is the professor at Ames. Thank you very much for joining us. Appreciate that. And of course, my co-presenter, Elena Gotti, Vice President of DIANOVA. And I am sorry that our co-presenter, Quetzali Manzano, from Mexico, will not be joining us today. But we appreciated the wonderful video from SPYM. And of course, that is a good introduction to the subject matter of gender-specific women's treatment. You saw a very sobering video. I guess this is a wake-up call for all of us, because in order to save the life of one child, one girl, one woman, it takes more than a village, it takes all of us. So this is also a clarion call to the women to the men in the program. For those men who are actively working to help women, I applaud you and I thank you to do that, because there's some outstanding men here. I hope you will get enlightened very soon. If not, I know the women in your household will get you there. Okay? And so this is a clarion call for all of you to get enlightened. A couple of words about me. I am Sushma Taylor. I am with the World Federation of Therapeutic Communities. In another capacity, I also am the Chief Executive of Centerpoint Incorporated. Our program is in California. That is where I normally hang my hat. A couple of words on a personal level. I was born here in Delhi many years ago. My father was an ambassador of the Indian government to many, and was very interested in empowerment of women and insisted on education for girls. Which is the reason why I stand today a very well enlightened and educated woman. He also never suggested that I should be less than my brothers were, and always suggested that we were on it. So I was almost raised on an equal footing as my brothers were. So for that, I've been very blessed to have had a very strong male figure in my life to encourage me to be the best that I can. And so for the men in the audience, I want to remind you that you have at least one woman in your life. That would be your mother. So make her proud, okay? Make her proud. And those of you who are lucky enough to have an enlightened wife, remember you may also have a daughter that you have to protect, a sister that you have to care for. So all of you remember that work to make sure that women are protected is a work that I want all of you men to remember. Okay? Yes. Yes, thank you very much. Okay. I needed to get that off my chest, okay? And so those of you who are doing that, I want to thank you very much. And some of you know who you are, because you are some of my very, very dear male friends, and I love you dearly. So some of you are sitting right here next to me. Okay. All right, so now on to the presentation. Hopefully I can get that off my chest. Could I get the next slide, please? Let's talk about women's treatment and what's the motivation for people to use drugs, okay? Sometimes it is a physiological need, it's psychological issues, and otherwise it's social or emotional. You saw the video today, and obviously there's a lot of social pressures that take place, but also it is emotional. They say people use drugs for two reasons. It is either for pleasure or it is for pain. We use drugs either to enhance pleasure or to alleviate pain. Next slide, please. Okay, now, what are the reasons that we discontinue use? Obviously, when we no longer can find it, we have impairment in health, family or friends might, employ some pressure. Okay, now in terms of substance abuse treatment, I have put these into various phases. Now, you can call them crisis phase or medical emergency. We can talk about the withdrawal phase of drug treatment. I'm going to go through some of these slides very quickly because because of time, number one, and number two, a lot of this information most of you know. Okay, the other thing is then there's the psychological stabilization. When we first started looking at treatment for women, I'm really talking more of the development that was done in the United States. We didn't really know much about women's treatment because most of the models for women's treatment were developed by women later, because most of the models that evolved were actually experiments that were done by men for men. Research was done by men for men. And so the models, and I do not say this with any disparity or disparaging comments, but it's reality. The early therapeutic community programs were run by men, and they were models that were designed for men. And so women were kind of thrown into the mix without really understanding the differences that women's needs that were required. Well, it took women to finally say, wait a minute, this doesn't work for us. And so some of us very early on went to the federal government and said, we need our own design. We need to have things that are gender sensitive. So we first started with the issues as gender sensitivity. Well, that wasn't enough. Then we decided to deal with gender specific. Then we decided, gender responsive. And I'm going to talk about these in a little more detail as we go. And then we came into trauma-informed. Next slide, please. And this evolution took a little time. Next slide, please. Thank you. Now, some of the reason for this is I looked at the demographics of the people that came into our particular program. A lot of them had criminal justice involvement, but 50% of the people who came into my program had physical or sexual abuse. 56% were abused as adults. 67% had domestic violence. You saw the video today. If you think that the girls who were abused as children did not get raised up to have abuse in their adult life, you're wrong. Okay? The abuse continues. The patterns continue until the patterns are addressed through treatment. Okay? Now, the data that was surprising for us is the family substance abuse. Now, most people don't collect this data, but for me it was important. 56% of our people had fathers who used drugs, 43% had mothers who used drugs, and 45% had siblings. So the disorder is a family disorder. So we needed a family response. So you cannot really treat the individual, you got to treat the whole family. Next slide. Okay, so let's talk about the trauma. Now, I'm not going to go too much into this detail because of time, so I'm going to pass this. Now, in terms of trauma, there are some very clear gender differences. Now, while men are greater exposure to trauma or traumatic life events, but women are at greater risk of developing post-traumatic stress due to trauma. Those are very interesting gender differences that we found. Men are prone to more physical violence and physical assault. And of course, we looked at issues of combat because we were dealing with some veterans that came through the war, certainly in our particular programs, and being held captive. Now, next slide, please. But when we looked at women's issues, there's more sexual violence there, sexual molestation, child physical assault, and of course, rape. But there was no differences in the genders for injury, death of loved ones, or natural disasters. So those gender differences were interesting for us when we were designing programs that we called family-based. Next, please. Okay. The consequences of trauma, I will let you just read the slide very quickly. I'm not going to go through it in the interest of time. But just some of the highlights. People who have experienced trauma, particularly sexual trauma, and some of the work that we were doing later on were with women who had gone through combat and had also been exposed to sexual assault during combat or post-combat. they really had some enormous exposure to trauma, including hypervigilance, as well as being anxious and emotionally distant. So you can imagine the compound issues that we were dealing with. Next slide, please. Okay, so when we looked at issues with women, we can look at where the trauma precedes substance abuse, and in terms of childhood incidents, adolescence, and adult, the trauma will lead to substance abuse. That's what our research and our experience has shown us. Now, you can talk about what they call evidence-based practice, but I also believe in practice-based evidence, okay? Which people don't necessarily talk about, but we do believe in practice-based evidence. A lot of the best interventions come from the clients themselves. We listen to the voices of our clients, we listen to their cries, and we listen to their anguish, and that is what makes us better clinicians. And so we need to meet the clients where they happen to live. Okay, so these things may precede substance abuse. Next slide, please. Now, on the other hand, when we look at the trauma that's associated with substance abuse, we can see that substance abuse that leads to trauma will result in continued use or increased use. And that's kind of the difference with trauma that's associated with substance use. The responses to stress or trauma. Okay, I've defined them into those 4 stages. Well, stage 1 is the realization that something major has actually occurred. And the stage 2, the second stage is the denial that it's occurred, or the numbness, the somnambulance that occurs that, well, it didn't happen to me, or it's not as bad as I really think, or I can get over it. Stage 3 is, well, that the denial about that it's serious, but then there is that repetition of feelings that come up at the strangest times, and you don't understand why the response was unexpected. Here's our gender responsiveness on the treatment side of the house. I described the phases of the problem. I'm going to give you the phases of the response. Phase 1. We need to provide sanctuary and safety for the people who have experienced trauma. I tell my staff that we need to provide 3 S's: safety, security, and sanctuary. The word sanctuary is an old word, and some people have used it to deal with refugees who have been fleeing from persecution, and they go to a place of safety, security, sanctuary. That's what some of our people do when they come into treatment. They are looking for sanctuary. Okay, in that phase, we want to give them stabilization and create a feeling of trust. We also want to manage their stress and begin a process of cooperation and a mutual communication pathway and process. Okay, so phase 2 is the phase where I suggest to my staff we start the exploration. And here's the exploration. It has to come on the patient's or the client's terms, not on the therapist's terms. We can't do it for them, okay? They have to do it for themselves. Okay, now, affective recall starts happening here. And this is when there is a lot of grief and mourning for the loss. But this is also a time where there is an opportunity for healing, for atonement, for forgiveness and letting go. Phase 3 is important because that's when there is a process of integration, learning new coping skills, resolution, and of course, connection to new patterns, new relationships, new friendships. Gender-specific issues that we want to take a look at in treatment. First of all, let's remember that female psychological development is very different. It is not the same as for women and for men. Female socialization is very different. Women are taught to be caretakers. We are taught to take care of people, of men. We have role expectations and demands that are different. We have cultural and sociological roles that are very well defined by culture and by religion in many places. And of course, families of origin have their own patterns of socializing the women and girls. And intimacy and relationships are also things that one should be thinking about. Just wanted to tell you that women who have been raped are not very prone to being free in intimate relationships, or on the contrary, they might get a little too easy to form pseudo-intimate relationships. So those are the things that we have to be watching for. We want to be looking at the psychological factors that deal with the onset of their addictive patterns, and also some of the issues that may exacerbate some of their healing. And I'm more concerned about cross-addiction to prescription drugs, and a lot of times we don't pay enough attention to that, because there is a lot of anxiety and a lot of feeling that perhaps a pill may alleviate the pain from within. Psychological factors that we have to pay attention to in treatment. Childhood trauma is a very important issue. We're always looking at now a lot of times the people who come into my residential treatment always have given me an indication that they ran away from their family because of incest or rape when they were young. And that is a trauma that they carry with them. Sexual abuse we've already talked about, which leads to dependent personality and sexual dysfunction. I have mentioned sexual dysfunction. Then there's learned helplessness. And of course there is eating disorders that do manifest themselves. And then this is a very important one, and loss of role. And this happens a lot, particularly when people have suddenly become either divorced or widowed, empty nest feeling. So there's role, the loss of role. If somebody who has been a parent and they've lost a child, either through a drug overdose, all of a sudden you feel like there's something missing. Yeah, there's a missing. It's not only missing the child, it's missing the role of being a mother, missing the role of being a sister. So there's an important factor that you want to think about when you're looking at the psychological factors when you're dealing with women's treatment. Women are complicated, people, okay? We are complicated. Our treatment needs are multi, and so your clinical hats have to be very, very keen. Let me talk about core program components. I've mentioned already safety, which is really, really important in any treatment setting. We want to make sure that the treatment setting is welcoming, sensitive, protective. I can't stress that enough. It has to be protected. We cannot re-traumatize people by being so harsh to immediately start let's start blaming the victim by asking what they did to get themselves in this situation. That's blaming the victim. Also, we need to start empowering them. A lot of times we start by giving them a multitude of questions to answer, long forms to fill out, which is really the wrong thing to do. Okay, we want to have the services to be trauma-informed and trauma-specific. And here's a big thing. Cultural competency is very important. I live in a state of California where we have a lot of different cultures, and in my program we will have obviously people who are Spanish-speaking, but the Spanish-speaking folks also come from different parts of the Spanish-speaking world. We have people from Guatemala, from Honduras, from Mexico, from Chile, then we have the Asians. They come from Laos and from Vietnam and from let's see, remind me, Ron, also from Cambodia. So we have a lot of differences even within the ethnic mix of the folks. So we have to be very sensitive to different cultures. In my program, we have what's called a cultural day, where we want our residents to talk about their cultural heritage and also to let the group know about the differences within their own cultures and what's important to them. I don't want to belabor it, but sexual orientation is an important factor, and we need to make sure that we do not discriminate in any way. Women-specific curricula, we need to provide good case management, clinical supervision for the people who are treating the women. Next slide, please. Okay. Here, we need our services to be strength-based and not what they call pathology-based. And we want to make sure we are trauma-informed. Next slide, please. And let's have our services family-focused. We need to make sure that the services are also provide interventions that strengthen the family systems, because they will eventually leave our programs and go back to their networks of support. And the networks of support can be their families and the community. So we go from the individual to the group that we are serving, to the family, either the family of origin or the new family that they connect with, and then eventually to the community. I've already talked about culturally competent services. You're welcome to use them as long as you give credit to the agency that has allowed me to do this work. You cannot be all over the map and say, well, I think I believe in this, or I think I believe in that. No, you have to have a clear philosophy where your staff have appropriate boundaries. And you've heard earlier people talk about having appropriate role models. And also we need to have the staff visibly advocate to reduce the stigma that is associated with addiction, okay? Because there is a lot of stigma, and so we have to stand up for for our clients and the work that we do. I'm about to conclude, but the environment. These are the five or six areas I want to leave you with that are very important. Attachment. We want to make sure these five elements are maintained. We want a culture of belonging for the clients. We want a culture of safety. We want a culture of openness. We want a culture of participation. And we want a culture of empowerment. That's very important. And so I leave you with these words.